Okay, Chapter 8, Airway Management. This is the first of only 2 chapters in Section 2 of the text. Section 2, while very short in the number of chapters and even in the number of pages, is probably one of the most important sections in the entire book. If we don't have airway and breathing, the rest of it really doesn't matter. So that's where airway and breathing and the management of those items comes in very important and is a big part of our job in EMS. So in Chapter 8 we'll discuss actually managing the route for the air to go in and out, and in Chapter 9 we'll actually manage putting the air in and out or assisting the patient or maximizing what the patient is able to do on their own. So we have our objectives, of course, that are listed in the textbook on pages 172, 73. Not a lot of them, but very critical ones at that. A couple multimedia slides that you can look at. Besides those multimedia slides, there's a large number of videos that have been placed in this week's course folder for the various different airway and breathing skills that you're going to need to know. There will be an additional PowerPoint or lecture on top of Chapter 8 and Chapter 9 that covers an airway device called the King LT airway, and there's various different types and subtypes, so there's a lot of material that will be covered this week. So I would suggest that everybody block off some time to spend looking at all of these different items. Of course, this will be a major portion of the first skills day that we have. We'll be doing a lot of lifting, moving, and airway management, respiration, and artificial ventilation, and probably getting into some assessment at that point as well. So, core concepts to look at the pathophysiology and the physiology of the airway, recognize adequate versus inadequate airways, and use methods how to open these airways and keep them open, and then of course suctioning. So we start with airway physiology. The first thing we look at is the upper airway, and if you want to take a look at the picture on 175 in your textbook, it has a kind of a mid-sagittal view of the upper airway. Your upper airway begins at the mouth and nose, either with the mouth, of course, is what we refer to that opening, and then the external nares is what is referred to as your nostrils. When the air runs through your mouth and nose, it gets humidified by taking up some of the moisture it finds in those cavities, and it can be run through a larger surface area if it goes through the nose. You can look at the turbinates. Those turbinates actually cover the openings to some of your sinuses, but they also create a lot of extra surface area for the air to kind of swirl around, or to be turbulent, to swirl around and get heated and humidified, just to make it more appropriate for the environment that it will be in the lungs. We have the pharynx. The pharynx is divided into 3 sections: oropharynx, nasopharynx, and the laryngopharynx. Please note that that is not pharynx, it's pharynx. It's like a lynx. But the oropharynx obviously is the cavity behind the mouth, nasopharynx the cavity behind the nostrils, and then the laryngopharynx is really where they kind of merge together in the back and become one as it heads down towards the glottic opening. Additionally, you can see in this picture a few other items. So it represents the sinuses. There's some other sinuses in your cheekbones as well. Those are your major sinuses that will occasionally become inflamed or infected and give us all kinds of heck. We've got the opening of the eustachian tube, which is in the nasopharynx. The eustachian tube actually leads to your middle ear, and that actually I should say your inner ear. It goes to your inner ear. The eustachian tube is one of the reasons why babies get ear infections so readily. In the adult, the eustachian tubes kind of run downhill from the ear to the nasopharynx, but when you're talking about babies, small toddlers, they're actually kind of horizontal. It's kind of flat, so it doesn't drain as easily. When it doesn't drain, it allows stuff to back up behind those eardrums, and you end up with some infection. You've got a few other items in there. It shows us the hyoid bone there, kind of at the base of the tongue, kind of anchors the tongue and the epiglottis and some of the thyroid structures, kind of anchoring point for all of those. We've got the tongue, of course, being a large structure, and pound for pound probably the strongest muscle in the body. It shows a few of the tonsils. Tonsils are really a lymphatic tissue, and those tonsils are kind of represented in the kind of greenish color there. Occasionally those obviously have to be removed, typically more so in childhood or early adulthood. And then we have the epiglottis. The epiglottis is actually that whole structure that kind of sticks up behind the tongue there, right by the blue arrow. And that structure is what covers the glottic opening to keep food and water out of it, or at least in theory it does. Occasionally things do slip by, and that's when we have kind of a choking or an aspiration. The vocal cords, which is technically the glottic opening between them, is really kind of the separating point between the upper and the lower airway, and we're going to get to the lower airway here in just a second. So here's that picture again. The lower airway, beginning at the glottic opening, is basically encased with, the beginning of it is encased within the thyroid cartilage. There's a cricoid cartilage that goes all the way around it. Cricoid cartilage is the only complete ring of cartilage that goes around that structure. Everything else is kind of C-channel shaped. We also have the thyroid gland in that area. It's not a respiratory structure, but it's immediately in that location. You have the trachea, which basically starts below the vocal cords there. And the trachea is the semi-rigid tubular structure that needs to be semi-rigid so it doesn't collapse under negative pressures. And it's the main windpipe that takes air down to the bronchial passages. If we want to look at the lower airway a little bit more, we can look at this picture and see, and you can also look in your textbook on 176, there's a picture of the bronchial tree as well. But we have the larynx, which is the structure in which encases the glottic opening, vocal cords. You got the trachea. You can see that it is a C-shaped channel, the backside of it being just smooth muscle, so kind of when you swallow something that may be a little too big and kind of feels like it sticks there, it probably is giving just a little bit of an intrusion into your trachea. Not nearly probably what it feels like. A lot of it might be really more a mental thing, but it is not a complete circled ring around there. So the trachea then goes down, it splits at the carina into the left and right mainstem bronchi, or also called the primary bronchi. These mainstem bronchi will then branch out and branch out and branch out and branch out and branch out until it gets down to, we have primary bronchi, secondary bronchi, tertiary bronchi. We get to bronchioles and we get to terminal bronchioles, which actually lead to the individual sacs themselves, the individual alveoli. And then the alveoli, of course, where the business actually happens. You see them talking about lung tissue there. It's the pinkish purplish color. That is actually, the medical term for that is parenchyma. It's lung parenchyma. It's kind of, if you wanted to think about it as, if you look at a sponge, you've got all the holes in the sponge. That would be like your alveoli. And the filler between the holes is the parenchyma, or that lung tissue there. I also like to think about a stem of grapes as being kind of the structure for a a lung. And you have larger sticks that become smaller sticks and smaller and smaller and smaller until it leads to just a little grape on the end. So that is kind of the general look and function of that lower airway. Of course, the real function occurs in the alveolus. Don't forget that there are numerous muscles that kind of go along with this. So we have things like the diaphragm being generally our main muscle for respiration, but we also have accessory muscles up in our neck and in our backs and shoulders and in our chest between our ribs. So those also play a big part in the whole respiratory process, the whole ventilatory process. So oh, come on, doesn't want to advance. There we go. The alveoli. These are the tiny sacs, kind of grape-like bunches. They are surrounded by a couple of things, actually. Not just pulmonary capillaries, but they are also surrounded by some little elastic bands that give them a little bit of stretch. So when you inhale, that allows to stretch out a little bit, and then when you just relax, it'll make them pop back down to their normal deflated size simply through the process of simple relaxation. And those elastic bands kind of help out with that. We'll eventually talk about a couple of different medical conditions that affect that. You probably have heard generalized term of COPD, or chronic obstructive pulmonary disease. That really affects a lot of the way that, particularly emphysema, affects the way that the elasticity of the lungs reacts and responds. Carbon dioxide and oxygen, they'll diffuse across these pulmonary membranes and will swap places. Basically, they look, if you think about something, a concept called homeostasis. Homeostasis is the body wants everything to be nice and equal and even, and I like to think of it as kind of a hippie theory, peace and love, man. But it wants everything to be equal. And so when you take in a breath of air, your breath of air has very little, minute, minuscule amount of carbon dioxide in it. And it has about 21% oxygen in it. Well, when it gets down to the alveoli, it compares notes with the blood, and the blood has considerably more carbon dioxide and considerably less oxygen. And so it says, oh, well, we got to fix that. So it diffuses across. So that carbon dioxide says, oh, I need to try to make it more carbon dioxide in the alveoli. And the oxygen says, I need to make sure that there's more of me in the blood. And so that diffusion occurs. Interesting fact here, if you take out all of an adult's alveoli, break them open, lay them out, they will cover at least half of a tennis court. That's how much surface area you have from the alveoli. So some airway pathophysiology and what happens here. Well, so a number of things can be a major issue for us when we're talking about the pathophysiology. We have small obstruction, or I should say obstructions from smaller items, variety of obstructions. It tends to be in kids, it tends to be foreign bodies such as toys or other things that they've found and just decided that, hey, that fits in my mouth, I'll put that in there. Of course, food is very common as well in kids, and in adults it's normally food. When we're talking about foreign body airway obstructions in the adult, it's usually has to do with a mind-altering substance as well. Occasionally we have pathologic problems that lead to airway obstructions. We get some blood, we get some vomit, knocked out teeth. Those can all potentially be there. Of course, we also can have some disease processes that will cause swelling and basically cause an obstruction that way. An obstruction can result from poor muscle tone caused by an altered mental status. In fact, if you are a snorer or you know somebody that is a snorer, they have a frequent airway obstruction. People who might have something called obstructive sleep apnea, usually the muscle tone has relaxed enough that it doesn't hold the tongue up where it needs to be, and some of the tissue becomes very relaxed, and it basically flutters in the breeze of the air going in and out. And so that's what sleep apnea is, OSA, obstructive sleep apnea. We might have things such as burns, blunt force trauma, that can cause some issues in there, causes a lot of swelling. Obstructions can be acute or they can be chronic. So when I say sleep apnea, that's a chronic issue. So introducing a couple of terms here, acute versus chronic. Acute is quick onset, new onset, rapid onset, hasn't been around a long time. Chronic, on the other hand, like chronic obstructive pulmonary disease, means you got it and it's been around and it's going to stay around, and it's a long-term process. So providers, you have to initially evaluate the airway and monitor its patency over time. People don't always have an open and patent airway. We got to make sure that we're constantly paying attention to it. Now, if the patient's sitting there talking to us the whole time, we're generally pretty sure that that airway is patent. But if they all of a sudden become quiet or start to be really wheezy or get something called stridor, which is kind of a high-pitched crowing sound, that's indications that an airway obstruction is coming about. And sometimes these are just kind of a spontaneous thing even while they're in our care. So, so in the lower airway, we sometimes will have smooth muscles become an issue. They're going to try to, they'll swell. You may get some mucus buildup in there, and this reduces that internal diameter of the airway. When we get a constriction from some of those smooth muscles, is referred to as bronchoconstriction or bronchospasm. And in those cases, when we're dealing with that, we have to think, how are we going to improve this process? Paramedics will give, and advanced EMTs will give, bronchodilator drugs such as albuterol. A lot of people have heard of albuterol or Proventil. So sometimes we end up having to ventilate the patient. Things that occur over time, we talked about that before, the decreased mental status and so on and so forth, edema from burns, getting a scald burn or a steam burn, and you inhale some of that. The hot fumes go down your throat and they burn everything. Bronchoconstriction, usually a disorder of the lower airway, and in most cases bronchoconstriction really is an issue of air trapping. We can actually move air in up to a point, but it's getting air out that usually becomes the issue. And so if we have some bronchoconstriction, we're going to temporarily be able to get air in until we've stacked the deck so much that nothing's gotten out, and then air can't get back in. So usually it starts out as an issue of exhalation. So our airway assessment, it's addressed in our primary assessment. Now it's introducing another new term here, primary and secondary assessment. Primary assessment is, we haven't covered this topic yet, but the primary assessment, the purpose of this, it's the very first thing we do. It usually takes all of about 60 seconds to do it, but the primary assessment is to find and treat any immediate life threats. So if it's going to kill you right now, we want to find that and address it in the primary survey or the primary assessment. Survey is kind of the older way we used to refer to it. So the primary assessment. When we get to the secondary assessment, that's really when we're spending a little bit more time looking at individual parts and pieces and maybe taking a closer in-depth look at things. But primary assessment is really a lot of the stuff that you've already learned in your CPR classes. It's ABCs. Airways, breathing, circulations. There's a few more steps to it when we're talking about EMS assessment, but that's really kind of the major gist of it. It doesn't take long, and you move forward. The two questions that you have to answer is, number one, is the airway open? If it's not, we have to address that before we go any further. Like I think I've mentioned early in this chapter, if we don't have this, the rest of it doesn't matter. If you can't even get air in, everything else is trivial. Once we have addressed if the airway is open, or we have opened that airway and have attempted to keep it open for them, we have to ask the question, will it stay open? Okay, sometimes it's very easy to open an airway. It's a matter of doing a head tilt chin lift or a jaw thrust that you probably learned in CPR. Will it stay open, on the other hand, without somebody sitting there constantly holding it open? Maybe not. So maybe we then have to look at what are some of our options. Is there a certain type of airway, an adjunct that we can put in there that will assist us in keeping this open? So we got to look at these two questions. And when we ask the question, is the airway open, we generally are looking at, is the patient able to breathe? Is the patient able to speak on their own? And if that is the case, they're talking to us, they have an airway. If they have some additional sounds when they're talking to us or breathing, such as gurgling, gasping, crowing, wheezing, snoring, stridor, like I said, is that high-pitched crowing sound, or the patient, those are all indications that there's a potential for airway obstruction. The patient may also present in what's called the sniffing position, and this is an attempt to keep their own airway open. We may come up to them, and it almost looks like they're trying to jut their chin out up into the air. And a lot of times it's basically them attempting to keep themselves from drowning when you see that. It's kind of like when you're in the pool and you can just barely touch on the bottom and you're reaching your chin way up there to try to keep your face out of the water. It's the same concept. Patients can have so much fluid in their body that they're essentially drowning. So we also will use the look, listen, and feel method for the unconscious patient. You should have learned this in your CPR or your BLS class, but just a quick reminder, we're looking for chest rise and fall, we're listening for air to move in and out, and we're trying to feel for air blowing on our cheek. So will it stay open? So this is something we constantly have to be looking at, because we're constantly reassessing our patient. We don't do just one assessment. We do an assessment and then we go back and we reassess and we reassess and we reassess. So if it won't stay open on its own, what can we do? Maybe it's a maneuver, maybe it's an adjunct. All right, so some additional signs of an inadequate airway. Foreign bodies in there, obviously. No air escaping. We don't feel it, we don't hear it. We have absent or minimal chest movements, and we have abdominal breathing. So to kind of explain a couple of these, number one, when we look at absent or minimal chest movements, most people don't breathe particularly heavy all the time. So it's something that we have to actually concentrate at watching for chest rise and fall. Particularly as we now approach winter, we're going to see bulkier and bulkier clothing. So as you see bulkier and bulkier clothing, it becomes that much more difficult to assess, is there good chest rise and fall. So sometimes we have to just watch very closely, and in those cases I suggest that you grab their wrist and pretend that you're taking their pulse while you do this, because if they think that you're watching them breathe, they're going to kind of modify their own breathing because they don't want anything to look like it's wrong. Everybody wants to be right. So if they think you're taking their pulse, they're not going to concentrate on trying to move or to change up their breathing. So an abdominal breathing. Now, most of the time people will breathe when they take a breath in, they inhale. Everybody take a big look down at your chest and abdomen, take a big deeper breath in, and almost always we see the abdomen come out, the chest come up and out. That's the typical setup here. Occasionally, and this is more so in kids, we'll see something called seesaw respirations, where they will breathe in, their chest will rise up and out, but their stomach will suck in. And then when they exhale, the chest falls and the gut pops out. And that's abdominal breathing. They're really using a lot more abdominal muscles in this process, and they're trying to compensate for inadequate breathing. Additional things we may see on the pediatric patient: retractions. Now, retractions isn't only a pediatric thing. Sometimes it's the very thin adults as well. But retractions are the soft spots in between the bones around the chest that don't necessarily stay where they're supposed to. So if they're sucking in very hard, they're really trying to work hard to breathe, they may pull down the areas, if you feel between, say, your collarbone and that big muscle mass on the back of your neck and back that kind of webs the back of your neck there, feel right behind your collarbones, that's a very soft spot there. Sometimes underneath the collarbone, sometimes between the ribs, or sometimes under the ribs in the border of the abdomen. Those are all places in which you may see some retractions. You may see skin sucking in when the patient's trying to take a breath. Additionally, we have nasal flaring in kids. And nasal flaring is when the nostrils open up as widely as possible to try to make a bigger airway. And when you open up those nostrils, usually it's on inhalation, the nostril flares open, and then on exhalation they'll kind of sink back to their normal size. And that's fairly common. Kids are obligate nose breathers. Adults breathe through their nose a lot as well, but young infants are really big nose breathers. So, all right. So in the non-lecture PowerPoint, you can go and you can watch the obstructed airway video. So let's talk about some ways to manage our airway, to keep it open, and to provide the best patient care there for those patients who can't do this for themselves. So when our primary assessment indicates that there is an inadequate airway, we have a life-threatening condition. We have something that we need to react to and respond to. So it means we are going to take a couple of potential maneuvers here. And then we've got to do this promptly to open and maintain that airway. And when we do that, we're going to use potentially one of two major methods. We should have learned this already, but the head tilt chin lift is what we would prefer to use. And if we don't have that at our disposal because the patient has a suspected trauma or an injury to their head or neck or their spine, then we're going to use the jaw thrust maneuver. If you remember head tilt chin lift, you place your palm of one hand on their forehead, a couple of fingers from the other hand under their chin, and rotate the head backwards. So pulling the chin up and rotating the head backwards. Whereas the jaw thrust, we have to try to maintain the C-spine, or the cervical spine, the neck vertebrae, in the neutral alignment. So we basically will give them earmuffs with our hands, put our hands over their ears, and then with our fingers we simply push on the angle of the jaw. So the back angle of the jaw, push that jaw forward. By pushing the jaw forward, pulls on the hyoid bone, pulls on the tongue, and hopefully it opens things up a little bit more. So for trauma, jaw thrust. For most other patients, head tilt chin lift. We have another maneuver that we're actually going to talk about more so when we're talking about specific airways and putting in airway adjuncts, but it's called a tongue jaw lift, where if you are a brave soul, you can take your thumb, stick it in the patient's mouth, basically push the tongue up against the floor of the mouth. Don't push it back in the airway. Push it against the floor of the mouth, and then just kind of gently pick up on the tongue, or on the jawbone itself, the mandible, and we'll pull that up, and that allows us to usually put in an airway. So here we show an example of the head tilt chin lift maneuver. couple fingers underneath the chin, palm on the forehead, tip the head backwards, pull up on the chin. Okay, so we place one hand, just like I said, tilt the head, lift the chin, and do not allow the mouth to close. They probably need their mouth open in order to help them move the appropriate amounts of air. Then we have the jaw thrust maneuver. And like I said, we basically give them earmuffs. We kind of take our hands, we put it over their ears with a couple of our fingers right behind the angle of the jaw there. And he's using his thumbs to actually help him out here. If you look at this as well, he is putting his thumbs kind of on their cheekbones, pushing against the cheekbone, but also pushing up on the angle of the jaw there. So do not tilt or rotate the patient's head if we don't have to. After the airway has been open, we got to position it to keep the airway open. Now, an additional thing I want to throw at you here is opening a child's airway. Children airways obviously are different than that of adults. We have kids who have very big heads, and proportionately when the head is much larger, then it will be pushed forward when the patient is laying supine or flat on their back. If you push the head forward, you are stretching the airway out of alignment and actually potentially causing an airway problem there as well. So if you have the opportunity, you have the resources available, pad behind a kid's shoulders. An infant probably needs somewhere around a half to 1 inch worth of padding underneath their shoulders to allow their head to kind of fall back into a neutral position. And really until they start to catch up, say by about their mid-school age years, that ½ inch to 1 inch of padding will help keep things aligned nicely. So additionally, after we've opened the airway, and we're going to try to keep it open with positioning, we also need to keep it clear of any secretions or other obstructions, and that's when both airway adjuncts and suction devices come into place. Like I mentioned, hyperflexion of the neck can cause an airway obstruction. So, and when we say hyperflexion, hyperextension is tipping it way back, or typically what people think we do when we do the head tilt chin lift. Hyperflexion is tipping it way forward, so chin to chest. So evaluate whether you need to pad behind their shoulders. And here shows a very good example of that pediatric airway. So probably don't need quite as much there, and they obviously have this exaggerated a little bit, but it gets you the same point. So on to airway adjuncts. So airway adjuncts, these are tools that we can use to keep the airway open. So they provide longer-term air channel. So when we do an airway positioning or a maneuver, it's short-term. So we open up the airway, we give 2 breaths, and we move on. And usually if we let go of it, we lose that airway. So when we add adjuncts to the mix, then we can keep the airway open for long periods of time. The two most common airway adjuncts we use in EMS are the Oropharyngeal Airway, also abbreviated to OPA. Sometimes this is just called the oral airway. Then we have the Nasopharyngeal Airway, abbreviated NPA, or often called the nasal airway. Any of them are appropriate. OPA, NPA are fairly standard abbreviations. When we're using airway adjuncts, there are certain things that we have to remember. They're not one size fits all. They are not always appropriate in one case and never appropriate in another. There is a few times in which orals have advantages to nasals and nasals have advantages to orals. Open the patient's airway manually before you use any adjunct. If you don't have the airway already open, it's going to make it more difficult to get that adjunct placed. And then when inserting the airway, take care not to push the patient's tongue into the pharynx. So if you would actually take and push that tip of the tongue back, you block the airway even worse. Have your suction ready. You don't have to have it on and in hand, but it should be sitting there right next to you, so it's a matter of flip the switch, pick it up, and then in you go. Do not continue inserting the airway if the patient gags, because oral airways in particular will make people gag if they still have that reflex. If they don't, this is definitely a candidate for an oral airway. And maintain head position after the adjunct is inserted. If a patient regains consciousness, they are not going to like having an adjunct in their airway. They are not going to like having this plastic hook in their mouth or this rubber tube down their nose. These are not going to be things that are particularly comfortable for them. You need to be ready to remove it. Luckily, they remove very easily, and again, if suction is readily available, you can suction if they would start to vomit. So the use of infection control practices while maintaining an airway is a must. You need to have your standard precautions. You need to have your gloves on, and you should probably have some face protection as well, something protecting the face from any spatter or splatter. So here's a oropharyngeal airways. These devices are used to move the tongue forward as it curves back to the pharynx. They are actually sized from really neonate to large adults, so some of them are as small as about 20 millimeters in length from tip to tip or tip to flange, and that 20 millimeters is really less than about an inch long. So an inch is to about 2.5 millimeters. I'm sorry, 2.5 centimeters, which would be about 25 millimeters. And they'll get as large as about 120 millimeters long. So that's going to be roughly 4.5 or so inches in length. And you're going to size them a specific way, and we're going to teach you how to do that. And there it is. When we size an oral airway, we take the oral airway, we kind of look at it, and we say, okay, what is going to be probably the correct size to start with? And we just kind of eyeball it, and then we'll grab that airway that we think is going to be close. We'll hold it up close to the patient's cheek, and we want one end of the airway at the corner of their mouth, the other end of the airway at the earlobe. So this is showing the correct sized oral airway for this gentleman, and they have obviously measured it there. When we're going to insert the oropharyngeal airway, you can either do the tongue jaw lift like I mentioned, where you grab the tongue and push it towards the floor of the mouth with your thumb and pick up on the jaw with your fingers. You can do a cross finger technique like they're showing here, where you basically are pushing on the teeth. That's probably one of the safer ways to do it. It's kind of cross finger technique while you push on the teeth. That way you know immediately if they're trying to bite down, and you can quickly get your fingers out of there. They're generally not going to be able to bite you. You're going to actually put this airway in upside down. So you see in the second picture here, it shows the curve is going the wrong way. Sometimes I like to tell people, basically pretend that it's diving off of their nose or their forehead into their mouth, and put it in upside down until their tip really just about touches the roof of the mouth. Once it basically touches the roof of the mouth, you can then rotate it 180 degrees, so the curve now follows the correct path. And then we want that flange of that airway to rest against their lips, and we will monitor them closely. If we're going to do a pediatric OPA, because the tongue is proportionately larger, we usually won't put it in upside down. We typically will take a tongue depressor, rigid tonsil tip, a bite blade, and then just kind of hold the tongue in place and then advance the OPA in the normal curve that we naturally see. We typically will not rotate it into place. An alternative, actually it works for either pediatric or adult, would be to go in sideways, so not rotated 180 degrees, but rotated about 90 degrees, and actually from, say, the side of the cheek, rotate it in so it goes in basically straight, and then once you get in, about halfway or so, you rotate it into place. And that generally works pretty well on either population. So the nasopharyngeal airway. The nasopharyngeal airway is used because it won't stimulate the gag reflex. The oropharyngeal airway will, so the patient has to be completely unresponsive in order for this to work with no gag reflex. The nasopharyngeal, on the other hand, if there's what people will often call semi-conscious, which is not an appropriate medical term, but they're not completely out, but yet they're not completely awake and alert, the nasopharyngeal airway may be a good fit for them. It is a soft, flexible tube that's inserted through the nostril and into the hypo or the laryngopharynx, and it moves the tongue and the soft tissue forward to provide a channel for air. When appropriately placed, you can, sized and placed, you can see the tip of that nasopharyngeal airway behind the back of the tongue. It can be used for patients with intact gag reflexes or clenched jaws. It is not comfortable by any means. If you put this in and it starts to stimulate your patient, they may quickly become alert, depending on what actually is their issue. It is contraindicated if there is severe facial trauma or you have fluids leaking from the nose or the ears. You would want to avoid using this. There are documented cases in which a nasopharyngeal airway was put into a facial trauma patient, and that actually the tip of it actually ended up in the patient's brain. That does not turn out well for anybody involved with that story. So they come in various sizes, and they must be measured. There are pediatric sizes. You don't see them very commonly, but you have to size them, and there's actually two different ways to size these, two different methods you have to use. So the typical sizes are 34, 32, 30, 28 French. There's a 36 French. There are some smaller Frenches than 28, but those are the most typical adult sizes. And the French system, the French measuring system, is it's directly proportionate. So when we say a 28 versus a 34 is a larger airway than a 28 is. Well, when we talk about other things such as needle size is inversely proportionate. So a 14 gauge needle is huge and a 24 gauge needle is very tiny. But the French is directly proportionate. So when we measure it, we are going to measure it from the earlobe, the earlobe or the crease of the ear there, to the tip of the nose. And that's the first measurement we're going to do. That's going to tell us if we have the right length. Now this one has a variable flange on it. You could push that flange down if it was just a little too long. The other thing that they don't show you is you need to look at and compare the nostril that you're going to stick it in with the size of the diameter of the airway. So you're not going to pick a 36 French airway when I say the French, that's determining what size around or diameter it is. You're not going to stick a 36 French in a little 4'8", 80-pound sopping wet grandma. It's not going to fit. It's just going to be way too large. So we need to lubricate the outside of the tube with a little water-based lubricant before insertion. Water-based lubricant could include water. Just a little bit of sterile water would also be fine. Typically, we'll have some sort of a surgical lubricant, such as a KY, which is they're showing a sterile packet here, to just lubricate the tip of that just a little bit. You don't need very much. A little bit of lube goes a long ways. Secondly, push up the tip of the nose and keep the head in kind of a neutral position, and insert into a nostril and advance until the flange rests firmly against the nostril. Now, what we don't have here is one extra step that they recommend for most patients. There is a bevel on the tip of this airway. And when I say a bevel, it's where they cut the tip off. And if you would look at page 187 in your textbook, picture number 2 versus picture number 4. Picture number 2 shows the non-flange side on the tip. It looks just like it's a standard rounded off tip. But picture number 4 kind of shows us, hey, there's that cut off edge, that cut edge in which is sliced very nicely. And it's best if we take that bevel and we put it towards the septum, which is the dividing part of the nose, what divides the two nostrils. And if we put the bevel towards the septum, so when we're putting it in the right side, it's the natural curve. When we're putting it in the left nostril, we actually have to turn it 180 degrees so it's curved away. So they're obviously putting it in the right side in the picture on the screen. Once you get the tip of the airway in, then you can rotate it around and it will slide into place. The reasoning for this is it causes a little less trauma on the capillary bed that's up on the septum of your nose. And suctioning. So suctioning is what we use when we have obvious liquids, usually blood or secretions, vomit, maybe something that they had to drink. And we've got to remove that from their airway to prevent it from being aspirated, which means sucked into, aspirated into their lungs. So when we have that in place, we use this kind of vacuum device in order to remove those liquids from the airway. There's a number of different types of suction we have. You can flip to 188-89 in your textbook. You see lots of different devices on these 2 pages. There's the wall-mounted suction in the ambulance seen on 188. It's usually kind of all compact and ready to go right there. There's a black knot. You see the dial. That's going to tell us how much suction is actually occurring. And then there's a black knob just to the left and below that dial. And that actually allows us to vary the amount of suction we're applying. If we look at 189, we have a couple of different portable style suction devices. Those portable style suction devices are obviously going to be used in the house, in the field, you know, for laying on the driveway or the sidewalk or whatever. These are mobile. The one that's mounted in the ambulance, it's mounted in the ambulance. It's not going anywhere else. This actual suction power is not coming from what you see here. It's coming remotely from a suction compressor that's behind the wall. So with the portable powered one, you might have an oxygen powered suction, which they show in A. They're not very common anymore. The oxygen powered suctions are few and far between. We mostly will use either what's seen in B or C. B is a battery powered portable suction device, and then C is a manual powered, so your hand. Basically, C is a really fancy turkey baster. A really fancy turkey baster is really what that is. That has a little bit of a reservoir to hold more stuff. So when we're looking at suction, we need to have our suction source, whether that's going to be our hand in the pump or an oxygen or battery powered or shoreline power or whatever. We have the collection canister or container, and in the case of the picture C in your textbook is called the VVAC. And in that case, it's kind of built into the suction tip itself. You've got the canister very visible on both the 188 and then on 189 in the portable suction unit, the battery-powered one. You have your canisters very easy to see there. Typically, those also will have a shutoff valve in them, so you can't overrun it. Tubing. Tubing is typically needed depending on what type of unit you have. Your powered units typically will have fairly lengthy tubing, somewhere 4 to 6 feet of tubing, whereas your manually powered device, you really don't need any tubing because you take the whole thing right there up into their face. But there is a little suction catheter there that can be used with the manually powered one. The suction tips or suction catheters are the two different major appliances that we use to actually remove stuff from. And we have a rigid tip, which is also called a Yankauer, and we have a flexible tip, which is often called a French. So again, here's some examples of fixed and portable. The portable on the left, fixed on the right. You see the tubing that's involved with both of them there, but they don't have any pictures of the tips themselves. Now, this guy's testing, or this gal, I guess, is testing the suction device, so it needs to furnish an air intake of up to 30 liters per minute at the open end of the collection tube, and it must generate vacuum of no less than 300 millimeters of mercury when the collecting tube is clamped. So that's what they're doing. They're trying to test this out, make sure that it works appropriately. So the rigid tip, or the pharyngeal suction tip, this is often called the Yankauer tip. It is a larger bore. This is very similar to like when you go to the dentist and they use that tip to suction your spit. Theirs is a little bit flexible, where this one is pretty much hockey shake all the time. It has a big hole on the end of it, probably a couple of big holes on the end of it, and it will suck up the fluids much quicker in some small particles. Rules for the rigid pharyngeal suction tip: you only suction as far as you can see. Don't lose sight of the distal end. You may need to do kind of that cross finger technique again to kind of keep their mouth open, as they're kind of showing you on 191 in your text. And carefully insert that tip to prevent gag, reflex, or vagal stimulation. Now, what's vagal stimulation? There's a couple of large nerves that run down either side of your throat, and those are the vagus nerves. Makes it sound like, all right, we're gonna go win at the slots, but that's not quite the same spelling. But the vagus nerve stimulates our heart, and specifically, if we stimulate the vagus nerve, it slows our heart rate down. So we want to prevent that if at all possible. When you are inserting a suction catheter or flexible suction catheter, whether it's rigid or flexible, we do not generally apply suction during that process. We wait until we have it in as far as we want it to go, then we will start the suction. We'll talk about how that happens here in just a second. The flexible suction catheter is designed to be used when a rigid tip can't be used. Sometimes paramedics will put it down a tube and suction out whatever that airway tube is. It can be used in the nose. It could technically be used if you needed to suction something out of any other orifice for whatever reason. You could use that. It can, and it's fairly pliable and easy to use. When we're using a flexible suction tip, these are also measured in French again. Yankauer come really one size. Well, I should take that back, two sizes. There's usually a pediatric and an adult size. But the French suction catheters are identified by a French number, large catheter, small number, small catheter, just like the nasopharyngeal airways. So this is really only going to apply if you need to feed that catheter down an airway or a tube. Otherwise, you get kind of the largest one you can find and use it. These are typically not large enough to suction vomitous or thick secretions. They can kink off rather easily. We can't always get them into places that we want them to go. And then in the event of copious or thick secretions, we may want to consider removing that flexible tip and switching either to the large bore suction tip or the rigid Yankauer tip. Or sometimes we'll just even take the tips off and we'll just put the suction tubing in their mouth, because the suction tubing has a huge hole in it, and it will suck stuff really quickly. Occasionally also we may want to take and dip the tip of our suction catheter into some water, some sterile water usually, suck a little bit of sterile water through it to kind of clean it out, and then go back to suctioning again. To measure our flexible suction tip, we're going to measure it the same way as we did an oropharyngeal airway. Corner of the mouth to the earlobe, and then you just keep your fingers right there. And that's as far in as you're going to go with that device if you're going to suction the mouth. If you're going in the nose, Just barely into the inside of the nose is about as far as you're going to go. So again, corner of the mouth to the earlobe is about as far as we're going to go, and they show you that there. Now, when we're going to suction a patient, obviously infection control is very important. There is going to be splashing, there is going to be fluids flowing, so it's a good idea to have taken precautions. I wear face mask, gloves at the very minimum. Sometimes you can get kind of a combo thing. You can see a guy in this picture here, he's got a combination eye protection and face mask on. Those are great. They're quick, they're easy, they're disposable. We generally suction no longer than 10 seconds at a time. If we had to go a little bit longer, definitely no longer than 15 on an adult, and then we scale it down the smaller the person. So in many cases with the adult, we want to steer clear of suctioning any longer than 10 to 15 seconds. On the child, say about 5 to 10, and really no longer than about 5 seconds on an infant. Should we be suctioning? Infants breathe so much faster. Prolonged suctioning can cause hypoxia and bradycardia, and if they vomit for longer than 10 seconds, you continue to suction. You try to get that out of there, otherwise they're going to suck it into their lung. If we're just talking little bits of secretions, that's one thing, but if we have a big pool in the back of their throat, we really want to try to get that out of there as quickly as possible. Place the tip of the catheter, where you want it to begin suctioning, and then suction on the way out. So you feed your tip in, then you start to suction. How do you apply suction? Both of those catheters typically have a hole up on the hand portion where the flexible tip connects into the tubing, or right about midpoint on the rigid tip, there's a hole. And that hole is actually going to be where most of the suction comes from unless you cover it. So you take your fingertip or your thumb, you place it over that hole, and then it directs the suction into the tip of the catheter as opposed to coming from that relief hole there. All right. So again, you can go to the standard PowerPoint and watch the suctioning video. So keeping an airway open and some definitive care. Things to consider. Number one, keeping an airway open may exceed the capabilities of you as an EMT. So this is definitely one of those cases where as we get further into class, we're going to find out. We may, if we have the option to call for paramedics, we may want to call for paramedics or call for ALS to come and assist us. Medications and or surgical procedures may be necessary to resolve airway obstructions. Sometimes even the paramedics aren't going to be able to handle it. It's going to require a physician. Now, paramedics have a lot of cool airway techniques they can do, a lot of neat medications, but none of them are foolproof. None of them are the end-all, be-all. So sometimes even paramedics are struggling to keep airways open. Rapidly evaluate and treat any airway problems that you find. When you find these, move on them quickly. Recognize them. If we need to, if we haven't already called for ALS or advanced life support, we should call for them. Maybe we have to divert. Instead of going to the patient's preferred hospital, which might be 15 minutes away, we may have to go to the closest hospital, which is 5 minutes away, simply because we need to have this patient with an adequate airway. They don't have an adequate airway. Again, we're going to be very short-term in this this call. This patient's not going to do well for very long. So if you were not able to manage an airway at the basic level, what advanced resources might be available to you? That question is something you're going to have to look at your local community. We'll say, for example, if you're around the Pottawatomie County area, which is the county that Council Bluffs is in, if you're not familiar, a majority of the agencies are basic life support, EMT. They may have a paramedic every now and again, but it may not be a constant thing. So if that's the case, there's one city in the county that has a hospital, and that is Council Bluffs. There are some others outside the county, but so a lot of the transports go to Council Bluffs, and if that basic level support or life support ambulance is transporting to Council Bluffs, they may call and say, ask Council Bluffs Fire and Rescue, which is paramedic level service. They may ask them to come out and do a tiered response, to come out and assist them. Maybe you're very, very rural and you have a town doctor, and maybe the town doctor is somebody that you could use. Or maybe you have to look at all the different potential situations. Facial injuries. When we're talking about facial injuries, this usually results in a lot of swelling and a lot of bleeding that can quickly give us airway issues. Bleeding may require frequent suctioning or a more definitive airway. When we get to the portion of this week's lecture that involves the King airway, the King airway is a nice improvement over a basic oral or nasal airway because it does help isolate the airway a little bit and helps, if we have, say, bleeding from the mouth, it would help keep the bleeding strictly in the mouth and not rolling down the airway. Obstructions. Many suction units are not adequate for removing solid objects, so sometimes we have to use manual techniques. Things that you learned in CPR class: abdominal thrusts, chest thrusts, back blows, finger sweeps. Tip the patient up on their side, sweep with your fingers to get any chunkage out. I have in my career seen patients vomit into a pile, not a puddle. They just got done eating, had a cardiac arrest, and they vomit. And that stuff is that they just ate comes right back up, and it is nowhere near being dissolved or being digested and moved on. So sometimes you will have this. So imagine some guy who's just had, you know, a supersized beer and the king-size porterhouse steak at the bar, and he's having a heart attack at the same time, starts to come home, and all of a sudden, bam, he falls over, there he is, and you know, you got this 20-ounce T-bone steak coming up, or porterhouse steak coming right back up there. It's not going to be pretty. Dental appliances. Dental appliances can either be very helpful or a huge hindrance, depending on what's going on. If they are firmly in place, leave them there. So they've used their C-bond dental wafers or whatever, their C-bond glue to help secure those in. Leave it alone because it gives you something to ventilate against. If it's just floating around in there, if it's loose, get it out, because if it's just loose in there, it has a high potential to become an airway obstruction. And then be prepared to remove if the airway becomes endangered. Pediatric patients, mentioned that before, that we need to try to pad underneath the shoulders. That helps push the airway into a normal alignment. Their mouth and nose is smaller, becomes obstructed easier. The tongue is proportionately larger, takes up more space in there. The trachea is much softer and more flexible. They haven't been able to calcify their cartilage yet, so it becomes very difficult for that to remain in when the patient's under a lot of duress. It becomes very difficult for that patient to not collapse their airway. The trachea is narrower and is easily obstructed by swelling. So if we would imagine a normal-sized drinking straw or a normal-sized just pencil, those are about the sizes that we're talking for an infant or one-year-old airway. So it's very small. And then the chest wall is softer, it's more pliable, and children rely on their diaphragm to breathe a lot more than they do the chest. And here's a good example of what we were just discussing there, how the head gets pushed forward, proportionately larger tongue, narrower trachea, and so on and so forth. So if we're going to manage this kid, open the airway gently. Do not hyperextend. put it up into what the sniffing position. The sniffing position is kind of just got your nose perked up a little bit. Consider adjuncts when other measures are failing. In most cases, we're probably talking an oral airway. Normally, we don't have nasal airways for kids. And then use a rigid tip adjunct to suction, but try not to touch the back of the airway if we don't have to. By touching the back of the airway, we may stimulate the vagal nerve and cause them to kind of clamp or cause their heart rate to come down. There's another problem with pediatrics, and now it's becoming even more of a problem in adults. It's a disease called epiglottitis. And epiglottitis, if you stimulate the epiglottis, it causes immediate swelling and almost an immediate closing of the airway. All right, so in our chapter review, where all this chapter is talking about is keeping that passageway open. How do we keep the passageway open for air to go in and out? Patient can't survive without it. This is something we have to always be ready to work on at a moment's notice. We have to be ready to suction when necessary. Personal protective equipment is a must. Airways change over time. Be ready to improve it or sometimes even remove it. Don't forget advanced life support is a potential option for you to call for assistance. So some things for you to consider: name the main structures of the airway, explain why care for the airway is first priority, describe the signs of inadequate airways, explain when you would use a head tilt chin lift versus a jaw thrust, explain the various airway adjuncts and suction and how they may help. In our critical thinking question, on arrival at an emergency scene, you find an adult female patient with gurgling sounds in the throat and inadequate breathing, slowing to almost nothing. How do you proceed to protect the airway? Well, in this case, you have to stop and think what potentially happened. Did we arrive, the lady's laying on her couch? There's probably less likelihood that she's going to have trauma, so we can probably do a head tilt chin lift. And we can then proceed to suction a little bit, put in an oral or nasal airway, and continue to monitor her airway that way. If we're talking somebody's laying in the middle of the street, chances are probably fairly good that there was a trauma, so we would need to use the jaw thrust instead of the head tilt chin lift. We would probably want to carefully assess her before we decided to put a nasal airway in her, make sure that she doesn't have any facial or head trauma. And then suctioning is still going to be appropriate. So when you're evaluating a small child, you hear stridor. What does this sound tell you? Stridor means airway narrowing, high upper airway narrowing. So, and our immediate concerns regarding the sound. Well, if we've had an immediate change in the pitch to a narrowed airway in the upper airway, that should drive us to think foreign body airway obstruction. Now, it's not always going to be foreign body. Sometimes it's swelling. But if we had this immediate change, we would think foreign body airway obstruction. If this was a gradual change, we would tend to think that this is probably swelling or this is some sort of a disease process. When assessing an unconscious patient, you note snoring respirations. You should be concerned with this, or should you be concerned with this? And if so, what steps can be taken to correct this situation? Snoring respirations generally means decreased level of consciousness, which goes right along with them saying unconscious. Should we be concerned with this? Yes, in general we should. We know that that is a potential airway obstruction. What steps can be taken to correct the situation? Well, we can line the airway up. We can, if they're on a pillow, remove the pillow. Let their head naturally relax back. We can do a head tilt chin lift or a jaw thrust, whichever is appropriate for the situation. All right,